Good morning, everyone, and thank you for joining us. Hopefully you will enjoy an extended tea break as you listen to Dr. Nick Sawyer from Cleveland Clinic London talking to you about a healthy lifestyle. I'll pass you over to Dr. Sawyer now. Thank you.
Good morning, everybody. Welcome to Cleveland Clinic's first contribution to Victoria Bid's webinar series. I'm going to talk to you about lifestyle and how it can influence your health, predominantly in the long term, but some of it in the slightly more short term. And I think this is a really good time for me to be delivering this webinar because it's 7 weeks after the new year and some people's resolve for their resolution may be flagging a bit. So it's always good to have a reminder of the best ways to look after yourself. I'd like to explain some of the science behind what most of you already know and have probably read or been told, and try and link that all together so it makes a bit more sense rather than just being told what to do. It's never too late to begin making lifestyle changes. So let's look at why this is relevant. If I could have the next slide, please. So, unfortunately, an unhealthy lifestyle is connected directly or indirectly with the major causes of death and disability in the Western world. This slide shows recent UK figures for the absolute numbers of deaths annually. If you group together the top one, the ischemic heart disease, and the stroke a bit further down, and I do that because the causative mechanisms are similar, and then you add the cancers, that is the majority of ways that most of us are going to die. But you've also got to remember that not all heart attacks and strokes are fatal. Some individuals are left with side effects, but others can make a full recovery with the support of medication and lifestyle changes. So let's begin to understand how lifestyle increases our risks of these diseases. And we need to look at to understand the basic mechanisms of stroke and heart attack. And fundamentally, that is furring up of arteries, like pipes in hard water areas. And what causes this furring up? Well, the answer is cholesterol. Thank you. So what happens is that cholesterol sticks to the walls of arteries. You can see that in this graphic. But how much sticks depends on how much cholesterol is in the blood, but also critically how sticky the walls of the blood vessels themselves are. We need to do a blood test to measure cholesterol. And what we're really interested in is the two subfractions of cholesterol, not the total. These are shown on the slide. Cholesterol is bound to carrier molecules, and these two carrier molecules are known as high-density lipoprotein, HDL, and you think of the H as being for healthy, and low-density lipoprotein, the LDL, and think of the L as being lousy. The reason this is important is because LDL cholesterol contains a lot more fat than HDL cholesterol. As it circulates, LDL gives off some of its fat to the walls of arteries and clogs them up. However, as HDL circulates, it scavenges fat from the walls of arteries and takes it via the veins to the liver to burn as energy. So we want more HDL and less LDL. The other factor here is that genes, and they play a major role in determining how much of each of these two types of cholesterol we have in our blood. And they can also influence how sticky the walls of blood vessels are. So this explains why not everybody with a high LDL cholesterol gets heart disease, and why not everybody who gets heart disease has got a high LDL cholesterol. But it is a factor we can control. I'm going to show you how lifestyle factors, diabetes, diet, obesity, exercise can influence these LDL-HDL ratios and the stickiness of blood vessel walls, both favourably and unfavourably, helping to reduce or increase the risks of heart attack and stroke. And some of these same factors in lifestyle also influence the risks of cancers. So making changes to reduce these risks can have a very positive effect. I'd like to talk about diabetes because that's very important in the terms, next slide please, in terms of the mechanisms here. So diabetes is all about insulin. If you eat some sugar, it causes the body to release insulin, so the level of glucose or sugar in the blood stays relatively constant. And it does this by moving glucose into cells to use it as energy, or into cells where it's stored as fat. And insulin also has a role in stopping fat being broken down to use as energy. So two types of diabetes. Type 1, insulin-dependent diabetes, they don't make insulin, they need to have it by regular injection. The irony is that type 2 diabetes actually have too much insulin. I'm going to explain why in a second. But 1 person in 16 in the UK has type 2 diabetes. They're almost always overweight, even if sometimes by very little. And they often have centrally distributed white, which is called visceral fat. But anybody, whether they're diabetic or not, if they've got excess weight around their middle, has this white fat. And this white fat secretes a chemical which pushes the body towards diabetes by making the liver and muscle cells less responsive to the actions of insulin. So what the body does is it makes more insulin to try to keep the glucose level normal. But the more insulin stops you breaking down the fat. So you wind up in a bit of a vicious cycle. So let's look a little bit at sugar in food on the next slide, please. If you take refined sugar, such as you find in fizzy drinks, and in fact a lot in fresh fruit juices, they're not always as healthy as they look, or when you put them in hot drinks or cakes and biscuits, this glucose is absorbed really rapidly. It's got a high glycemic index, a high GI, and this causes a higher output of insulin than does the slowly absorbed carbohydrate shown on the right of the slide, such as starchy root vegetables, pulses, and oats. They've got a low glycemic index, a low GI. So high GI foods stimulate more insulin production. And as we've just seen, high insulin levels are not good for you. So the point is that over time, diabetes, but possibly the excess insulin itself, damages the walls of blood vessels. It makes them more sticky as far as cholesterol is concerned, and also less elastic, leading to heart attack and stroke, as we saw above. Let's look at obesity on the next slide. There's a lot of talk about obesity. First thing is, how is it measured? So it's body mass index. It's the weight divided by the height squared. Metric is easier, but you can do it from SI units. So generally accepted ranges are shown on the slide here. The bad news here that you can see is a greater proportion of the UK population is at an unhealthy weight, 65%, than is at a healthy weight, 30%. Males tend to be worse than females, and there are some regional differences. Sadly, currently the UK is the fattest nation in Europe. It's also helpful to look at the distribution of the weight, so we measure the waist circumference. What I mean by this is around your umbilicus or belly button, as this is the widest part of your stomach. It's not your trouser size, which is less, as it's usually a few inches below your umbilicus if you've got a belly. A healthy waist measurement is less than 35 inches for women, 89 centimetres, or 40 inches or 101 centimetres for men. At the end of the day, bellies are bad for you. Bellies are full of white, visceral fat, which is stuff I talked about earlier on. And white fat in the liver causes something called fatty liver. Fat actually damages the liver cells, and the abnormality that it produces is in the same pattern as heavy drinking, and can have the same end result, which is cirrhosis, which means effectively liver failure, which is usually leads to death. But it also results in double the average rate of primary liver cancer, and that's not a good cancer to have. So we'll talk a little bit more about obesity and cancer on the next slide, because fat produces extra estrogen, and high levels of estrogen promote breast tumours. It also produces another hormone called insulin growth factor 1, which promotes the development of colon cancer, kidney, prostate, and uterine cancers. And on the slide, we show cancers that are at least twice as common in obese people as in non-obese people. And in fact, overall, it's been estimated that about 4% of male and 10% of female cancers are due to obesity directly. So next slide, if that's not enough, the risk of developing ischemic heart disease doubles if your BMI goes from 20 to over 30. Complications arising from surgery for cancers are significantly greater in obese people. They get blood clots in their legs, they get pneumonias. And you're probably aware, because it's been in the press, that the risk of death from COVID can be as much as 40% higher if your BMI is greater than 35, relative to it being less than 25. Another condition associated with obesity is something called obstructive sleep apnea, or OSA. This causes daytime sleepiness and can lead to falling asleep inappropriately. For example, when you're driving along a boring motorway and you cause an accident. High blood pressure, that's more than 140/90, they're the magic numbers, is linked to obesity. It's about twice as common in overweight individuals, but 4 times as common in obese people than in those with a BMI of less than 25. And if you manage to lose 10% of your body weight, you can lower your blood pressure by about 5 points. High blood pressure is a major risk factor for heart attacks and strokes because it damages the walls of blood vessels and makes cholesterol stick to them. So there's a common theme here in terms of what's going on. So if we can move on to the next slide, we're going to look at lifestyle, and we're going to look at diet, exercise and stress in relation to that. And we'll start off with diet on the next slide. I have a very simplistic approach to that, which is that if your weight's too much, you've been eating more than you need. And many people are amazed at how little they need to eat to survive and to induce weight loss. And the reason for this is that from an evolutionary point of view, it's a survival advantage to be able to slow your metabolic rate down when food is in short supply. And that's exactly what most people's bodies do. And this makes it even harder to lose weight. The slide shows the average daily requirements for middle-aged males and females. And to lose weight, if you're very efficient at slowing your metabolic rate in response to the fewer calories coming in, you're going to need to get down to 1,000 calories a day or less and keep it at that for some time. So what we can do to improve our diet, I'm going to go through a few food types and give you some things to think about when making food selections. I'm going to start with carbohydrates. We've already mentioned them because sugar's a carbohydrate, and we've seen how this causes raised insulin levels and possibly leading to diabetes, and we've looked at high and low GI foods. But when talking about carbohydrates, we can't forget alcohol, because these are hidden carbohydrates, calories, and they're often forgotten when people discuss their food intake. But as you can see on the table, alcohol actually contains quite a lot of calories, particularly if you're exceeding the government recommendations, which are now 14 units a week. And they've made those apply now to both sexes, as opposed to the increased quantities that used to be set for men. So we move on to the next slide, which is fats. There are an awful lot of calories in a small amount of dietary fat, so it's very easy for them to contribute to weight gain. But there's more to it than that, because you can simplify fats into animal fats, which are saturated fats. And generally they're bad because they raise the LDL or lousy cholesterol. And unsaturated fats found in fish, which are generally good because they raise HDL and lower LDL. Generally speaking, plant foods also come into this category of good fats, but the exception to that is palm oil. And palm oil is ubiquitous in shop-bought, long shelf life cakes, and that causes substantial increases in LDL cholesterol. So we move on to the next slide, some other aspects of diet, and we move on to protein. So protein provides the amino acids, the essential building blocks of muscle. And if that protein comes from red meat, it also brings iron, which is required for making hemoglobin and stopping anemia. But it's also going to bring animal fats. Fish protein is going to bring healthy omega fats, as we've seen. When eating meats, you ought to be aware that processed meats have been classified by the World Health Organization as class 1 carcinogens. So they've been proven to cause cancer. So ham, bacon, salami, frankfurters all cause cancer of the stomach and colon because of the nitrate preservatives within them. Most non-vegetarians in the Western world eat more protein than they need, which is something that possibly should be addressed going forward. The problem is plant proteins don't include all the essential amino acids, and those that are present tend to be in lower concentrations, although edamame beans and chickpeas have got relatively large amounts of protein. Vegetables are very valuable in our diet. Fibre in vegetables reduces constipation, helps bowel function, and the brassicas, as they're listed on there, contain glucosinolates, which are antioxidant and may reduce cancer. Generally speaking, the darker the vegetable, the better. Down the bottom left, salt. So shop-bought produce is labelled quite often in a rather confusing fashion. The maximum daily intake recommended by the NHS is 6 grams of salt, but that's 2.4 grams of sodium, depending on how they show it. And some literature suggests that even lower levels than that are preferable. Intrinsically high salty foods include anything that's preserved, like cheese, ham, and smoked fish, as well as anything that says it's salty, like salted crisps and salted nuts. But there are also foods which we're tempted to add salt to, such as chips. Unfortunately for some people, that includes anything on the plate. Other significant contributors to dietary salt are bread, ketchup, and many breakfast cereals that people are often not aware of. Part of the reason a high salt diet is bad for you is because it contributes to high blood pressure. And we've seen how this damages the walls of blood vessels. High salt diets are also linked to osteoporosis, stomach cancer, and kidney stones. And there are alternatives increasingly available, such as potassium chloride or combinations of the two, and you might look into that. So vitamin D, again, been in the press recently. Everyone in the UK should be taking a vitamin D3 supplement, which is available over the counter. This was recommended some time ago by NICE, the National Institute for Clinical Excellence. They put out a lot of guidelines for best practice. And they suggest 600 international units, that's how it tends to be branded in the shops, or 15 micrograms every day. But actually, I think 1,000 international units or 25 micrograms is probably better at the moment, because there's even less sunshine than usual in the winter. And there is some suggestion that there may be some protective benefit against COVID. However, as this vitamin is stored in the body, it is possible to overdose on it. So potentially, that's not a good thing, and taking very high dose supplements over a long period of time may not necessarily be very good. Most people don't drink enough water. We should be drinking about 1.5 litres a day. And the reasons for that are to help prevent constipation, because the body will use the water content of the large intestine as a reservoir if it's not got enough. And once it's taken the water out, it can't put it back, and you get constipated. High water intake also helps with urinary infections, kidney stones, and gout. It also reduces bad breath and tooth decay, which occur due to reduced saliva production. And it's quite interesting that the thirst mechanism in elderly people seems to fail. So elderly people don't feel thirsty. They need to be reminded to drink. So if we move on to the next slide, finally in diet, be aware of portion size and hidden calories. Aim to include more unsaturated fat in your diet, but are balanced. Be aware, very aware of processed red meat consumption. Vegetables, generally the darker the better. Take some vitamin D and drink at least 1.5 litres of water a day. Let's move on to other aspects of lifestyle on the next slide. So we'll look at exercise. Always difficult. We at Cleveland recommend 2.5 to 5 hours of moderate exercise, which is brisk walking or gentle riding a bicycle a week, or 1 to 2 hours of vigorous exercise, jogging, running, team sports, things like that. Other people would say twice a week of strength training a different muscle group should be added to that, and there are various other suggestions. Unfortunately, whichever target we set, most people don't quite reach it, but anything's better than nothing. It really is. Having said that, a recent study showed that those who are in the top 25% for how much exercise they do reduce their risks of heart and circulatory disease by 50% compared with the bottom 25%. And part of the explanation for this may be that sustained aerobic exercise converts LDL, the bad stuff, into HDL, the good stuff. So it's win-win. And there are clear health benefits from exercise, irrespective of weight loss. In fact, exercise really isn't very good for weight loss, unfortunately. It really needs to be in conjunction with the diet. If you've ever looked at how many calories you burn in an hour on a machine in the gym, you will be very disappointed, I'm sure, to learn that 1 kilogram of body fat contains nearly 8,000 calories. It's not the way to lose weight. Weight loss is 90% diet and 10% exercise. However, exercise has other health benefits. It improves mental health and mood because of endorphins. It improves sleep. It improves muscle tone and reduces falls in the elderly, and lots of other potential benefits. Another aspect of lifestyle is stress on the next slide. Bit of a difficult concept. You can't put it on a set of scales and measure it. And it's determined by a combination of actual circumstances, but often important perception of circumstances. But the reason it has a role here is because it releases adrenaline, and adrenaline raises your blood pressure, it increases your circulating LDL levels, and it increases blood glucose levels, and therefore insulin. Some recognized workplace stressors are heavy workload and long hours, career and job uncertainty, organizational change, lack of recognition of contribution, poor personal working relationships, and harassment and bullying. And personal stress can also add to it. That can be good, a bit of nerves before a wedding, but it distracts you from work nevertheless. Or bad, if a member of family is really ill, you can be very distracted from work and much less robust to dealing with workplace stress. And financial stress is very important, whether that's real or perceived. So the management of this tends to focus on communication, early intervention, and that includes managers being much more mindful of stress and trying to identify it early. And we don't have time to go into treatments, but it's cognitive behavioural therapy, coaching, mindfulness, all of these things have been shown to be very valuable. Move on to some very important lifestyle issues. And although a lot of attention focuses on illegal drugs, they really only cause about 4,000 deaths a year directly, although many more indirectly. And legal highs, which are popular because you can't be prosecuted for them, but they're very dangerous because hospital A&E departments don't know what you've taken, and it's very difficult to treat people who've taken things like that. But what we should really focus on is smoking and alcohol. So tobacco kills nearly 80,000 people annually in the UK, and it accounts for 500,000 hospital admissions. It's responsible for 30% of all cancer deaths and 80% of lung cancer deaths. But not just lung cancer. The majority of cancers of the larynx, the voice box, the mouth, the esophagus or gullet are also a direct consequence of smoking. And cigarettes also contribute significantly to the risks of bladder, kidney, liver and stomach cancer. Going back to the other sources of things that kill us, nicotine acts on the walls of blood vessels. It makes them stickier for cholesterol, and it also causes them to narrow. If your third arteries narrow whilst you're smoking, that can lead to a heart attack. And there are lots of advices and ways to try to reduce cigarette consumption. Alcohol, fewer deaths, about 10,000 directly, but 1.25 million hospital admissions a year. Most of the deaths are from cirrhosis, which is the liver failure that we talked about with excess weight, but others are from accidents and mental illness. And unfortunately, alcohol also produces cancer. Generally, the parts of the body that come into direct contact with the alcohol, the esophagus, the gullet again, the mouth. And interest is also increasing in the role of alcohol in breast cancers, although clearly not in direct contact with it. So we'll move on to a summary of some of the key takeaways from all of this on the next slide. Cholesterol, diabetes, obesity all contribute unfavourably to our quality of life by affecting cholesterol sticking to walls of arteries mostly, but also to cancers. Improving diet and exercise, reducing your stress, and being aware of your consumption of alcohol and tobacco are all very important in improving your quality of life going forward. So it's been a bit heavy, I'm afraid, but I hope by now I've managed to show you the extent to which lifestyle can contribute to illness and poor quality of life, and more importantly, how you can try and reduce that. It's often difficult when you're young, you feel invincible, difficult to see the benefits of investing in a healthy lifestyle to avoid an unhealthy middle age somewhere in the distance. And it's a bit like saving for a pension in many ways. On the other hand, if you're middle-aged and you've had years of bad habits, it's not too late to make changes. Even small continued changes will result in positive changes. Finally, leave you on a slightly humorous note regarding lifestyle, so stupid, risky behaviours. There's a fabulous website called the darwinawards.com, which you might look at. These honour Charles Darwin, the father of evolution, and commemorate those who improved the global gene pool by removing themselves from it in the most spectacular way possible. Thank you very much for your time. Take care.
Thank you very much, Nick. I actively invite those who are listening to send questions on the Q&A or the chat. But Dr. Sawyer, we have had a couple come through, which I'm hoping you could answer.
Sure.
Thank you very much. There was a question on vitamin D, which you alluded to. It has been in the press a lot recently. Despite COVID, would you still recommend the supplement? And in your opinion, what do you see as the key benefits?
I think vitamin D is really very interesting. it was discovered about 100 years ago or thereabouts, initially as a cause, deficiency of vitamin D as a cause of rickets, of bow-leggedness in children and bones not growing properly. And its primary role in the body was thought for many years really to be to make sure enough calcium was absorbed and then put into the bones to make them strong. But interest has increased recently in its role in the immune system, possibly in suppression of cancers, and it seems to have a much wider role. This recommendation for NICE is buried in a huge amount of dry print from them. But I think it does seem quite clear that everybody in the UK, because we're so far north of the equator, should be taking a vitamin D supplement. The reason for that is that vitamin D is synthesized in the skin by ultraviolet light. And even if we do manage to get out onto the vaguely sunny days in the UK, the UV is not at sufficient concentration to have a really good effect. And if we've got pigmented skin or we are culturally covering up our skin, we get even less access to vitamin D. So it's even more important in people in these groups. It does have some role in respiratory infections and therefore may have a role in protection against COVID. And there has been a suggestion that one of the reasons that people from the BAME community are more unwell with COVID is because they do tend to run lower vitamin D levels for the reasons that I've just alluded to. So I think vitamin D is incredibly important. It is possible to overdose on it, so you do need to be slightly careful. It's almost impossible that you're going to overdose it on 1,000 international units a day, which is a little bit more than the NICE recommendation. And that's where I would set it generally. So I think everybody should be on a vitamin D supplement. And I think that the future may well reveal further evidence of cancer suppression and boosting of the immune system as we increase our understanding of it.
Thank you, Dr. Sawyer. Another question about sugars. You've talked about refined sugars. Are artificial sweeteners a good substitute?
I think the answer to that is yes. There was some strange publicity suggesting that artificial sweeteners could actually raise your blood sugar level. And some of that was demonstrated experimentally when they fed huge quantities to rats. And there was a suggestion that as you perceived something sweet in your mouth, it stimulated a little bit of release of insulin. But in practice, that really doesn't happen. I think that there's no question that if you've got diabetes, pre-diabetes, or you're overweight, you're far better to switch to a sugar substitute. But as with anything that's a synthetic chemical, you shouldn't really be taking too much of it. But 1 or 2 portions a day, it's not going to do any harm and will reduce your intake of refined sugars, and therefore that can only be beneficial.
Thank you. There is a question on the chat that's come through. Someone asking for their partner who's taking warfarin and lithium. Would vitamin D be a suitable supplement to take with those 2 medications?
Yes, I can't see any potential for interaction there. I think it would be entirely reasonable for them also to take vitamin D. Possibly stick to the 600 international units rather than 1,000, but there's no, vitamin K is the vitamin that's responsible for blood clotting, which warfarin is antagonizing, warfarin's acting against. So no, vitamin D would be fine. Thank
you. And they have also just added, is a COVID vaccine safe for those who are taking warfarin and lithium?
The answer is it's absolutely safe. I think that it's important that the patient notifies the vaccination centre that they're taking warfarin. But the worst that's going to happen is you're going to wind up with a bit of a big bruise at the site of injection. But as long as you put your finger on it for long enough, for hard enough afterwards, you would be all right. But the people giving the vaccine would give more specific recommendations on that. But it certainly would not be a reason not to take it. And in fact, if you've got a medical condition that requires you to take warfarin, I would think almost certainly it would be actually even more important that you took the COVID vaccine when it was offered to you.
Thank you, Dr. Sawyer. Another one that's come through privately, but on a similar stream, actually. There's always a lot of controversy surrounding statins. The person asking says, my husband has just been prescribed simvastatin and he's reluctant to take it. What would you advise, please?
I think that there's been a lot of negative press about statins. It only takes one small report suggesting that there's an adverse consequence of it for it to feature on the front page of some of the newspapers. What they don't publicise is the hundreds of thousands of other papers that have been published that show the beneficial effects in reducing heart attacks and possibly strokes, but primarily heart attacks associated with taking statins. I think if the doctor has come to a conclusion that there are sufficient risk factors to warrant taking a statin, then I would have no hesitation in endorsing that. And in fact, I think there's even been a newspaper article in the last 48 hours suggesting that the thoughts of statins producing muscle pains is largely fiction. And I've had a number of patients who feel that their statins have possibly caused them to have muscle pains. So we come to an agreement. They start the statin for a month. It's fine. If you're going to take it, you're going to take it probably for 20 years, months neither here nor there. And in more cases than not, the muscle aches and pains are just muscle aches and pains associated with the aging process. They don't change whether they're on the statin or not. And they then are usually very happy to return to taking it. There are a very, very small minority of the population who genuinely have problems associated with taking the statin. And they should be checked 2 or 3 months after starting it by the doctor who started it. But if they've not shown it after that period of time, they're almost certainly not going to. And they are very effective drugs for what they're designed to do.
Thank you. Thank you, Dr. Sawyer. This question has made me smile because it's someone who I think is looking forward to June the 21st, if all goes to plan. They're asking about the damage from binge drinking specifically, asking if I save my units throughout the week to have them at the weekend. What are your thoughts on that?
I think that there is good evidence for having some days not drinking alcohol, as opposed to ensuring that you have either 1 or 2 units on every single daily basis. But on the other hand, there is also fairly strong evidence that binge drinking is not good for you. If you save all that much alcohol up for a fairly short period of time, you're at greater risk of intoxication and injury. And the liver seems not to like sudden big exposures either. So I would suggest that you should have a couple of days alcohol-free a week, but not necessarily use up your entire allowance just because it's the weekend.
Okay, thank you. The last question that's come through is, you've talked about the benefits of exercise. How long do you need to be doing the weekly amount of exercise recommended before you see some health benefits?
That's interesting. And I think that the answer to that is that the health benefits are incremental and differ according to what benefit you're looking for. You will get some benefits from doing that within as little as 2 or 3 weeks. And what you would hope and expect is that over time, your fitness level will increase. Now that time is much more of the order of 3 or 6 months. And you'll find that you can more easily do the same amount of exercise you started off doing, or for the same amount of effort that you put in at the beginning, you can get more out, you can do more exercise. So it depends exactly what effect you're looking for, but there have been shown clearly to be metabolic changes within as little as 3 or 4 weeks, the beginnings of them, and those metabolic changes will continue and will improve further, and fitness levels improve, muscle tone improves. And muscle at the end of the day is much more metabolically active than fat. So you can buy these scales quite easily these days. You can buy scales that measure body fat. You stand on them barefoot and it produces an undetectable tiny electric current through and measures the amount of fat in your body. What people will see if they exercise, even if their weight stays the same, they'll see that their percentage of body fat falls. And if you've got more muscle, it's more metabolically active. So your resting metabolic rate is going to go up. So you've got a better chance that you will lose a little bit of weight by having a slightly raised metabolic rate, not necessarily an immediate direct consequence of the calories you burn when you're exercising, but a longer term increase in your resting metabolic rate that will be burning calories for you all day long.
Thank you, Dr. Sawyer. Sorry, there has been one last question pop through. I'm not sure if it's the same person who asked about binge drinking. What about binge eating? Is it an issue if you save up eating all your sugary food to the weekend? So I guess they're saying if they're really good throughout the week and then have, a naughty Saturday. What are your thoughts on that?
No, I think that would be absolutely awful. I think that if you're going to subject the pancreas to a massive amount of sugar, you're going to get a massive amount of insulin released to try to compensate for that. And what we don't want is a lot of circulating insulin going around. We just want a nice steady trickle of insulin, which is why we talked about the low GI index foods, the foods that are absorbed slowly. A little bit more sugar leaches into the system, a little bit more insulin gets put out. You do not want a massive amount of sugar going in and a massive amount of insulin being produced in a short period of time. That I would definitely say that's not a good idea.
Okay, no, thank you. After this question, because I think this is one that you touched upon in the presentation, I will have to end it there, I'm afraid, everyone. Thank you for all your questions. How important is sleep to health, and how much do you really need per night?
I think sleep is very important to health. There's a lot of talk about how it helps the brain to readjust its filing cabinet and put everything into place and move things from short-term memory into longer-term memory. It helps to reduce stress levels. It helps to reduce adrenaline levels. If you're deprived of sleep, the only way that you can continue to function effectively is by raising your adrenaline levels. And we saw in the webinar that raised adrenaline levels are a source of raised sugar, raised LDL cholesterol, raised blood pressure. All these things were relevant when you were being chased by a saber-toothed tiger. You wanted a lot of adrenaline. You wanted all this sugar and fat in your blood that you could then burn as energy so you could run that bit quicker. But it's not good for us now. So sleep is important because if you've not got it, you're going to be generating adrenaline. Putting a number on it is very difficult. I mean, they used to say Maggie Thatcher slept 2 hours a night or something ridiculous. And everybody knows people who will say, oh God, I felt terrible. I didn't get my 8 hours last night. And other people who say, oh, I had my usual 5.5, 6 hours. I feel absolutely fine. So I think there's a spectrum, which is probably genetically determined of how much sleep we need. And I think most people have probably got a reasonable idea from past experiences where they fit into that, how much they need. So it's enough for you is what you need. But if you're not getting enough, it is definitely not good for you.
Okay, thank you so much, Dr. Sawyer, for your time this morning and that presentation. And as you started by saying, I think a lot of this is things that we know, but we constantly need that reminder to just keep us on track, make sure we're making the right decisions. I just want to say thank you to everyone for your questions. We got quite a few coming in towards the end. And thank you for joining us, and hope you enjoyed your tea break. Thank you very much.
Thank you for listening. Take care.